Today we are going to discuss how to examine a suspected ligament injury of the knee. If patient comes to you either in the examination or in the hospital, how are you going to examine it? By definition, a ligament injury is overstretching or tearing of the ligament. There is a sound which is usually comes in play when we discuss about the ligament injury. It is called pop sound, and usually it is heard in almost all of the ligament injuries. Anterior cruciate, posterior cruciate, medial and lateral collateral ligament, and rarely it can be heard in the cases of meniscal tear and also patellar tendon tear. Differences in the male and the female ligament injuries, and they are very contrasting ones. The ligament injuries in the females are far more common, the ratio of 4.5 times more than the males. And the females sustain ACL injuries, especially at an younger age than the males. And they get more of the ACL injuries on the supporting leg, whereas the males get more ACL injuries on the kicking side of the leg. Anatomy I won't be discussing quite a lot. Suffice to know that anterior cruciate ligament consists of two major fiber bundles, and they are named as anteromedial and posteromedial bundles. We will discuss it, and it is more discussed among the surgeons during the repair or the reconstruction of the ligament, whether both the bundles should be reconstructed or only one is sufficient. Why PCL tear is less common than ACL tear? The PCL tear requires a huge force, and that's why it is much rarer than the ACL injuries. There can be different types of ACL injuries. Avulsion injuries can be partial injuries, can be complete injuries. Avulsion injuries means part of the bone from the tibial spine has been avulsed along with the ACL or anterior cruciate ligament. Ligament per se is not torn, but the effect remains the same, it becomes lax. The symptoms, as we have seen, the sound, the popping sound at the time of injury. Knee swelling usually occurs within 6 hours of the injury, especially in the ACL and PCL injuries. In lateral and medial collateral ligament, unless it is complete one, the swelling does not come in the knee. Pain, especially on weight bearing, they cannot continue with the sport, and in later cases, feeling of instability, which the patient describes as giving away sensation. Is pop sound in the knee caused by a fracture? No, it cannot be. The loud pop that is accompanied by immediate pain is usually caused by tear in one of the 4 ligaments. Pop usually is a sound that is produced by tearing of soft tissues. Is a pop in the knee the same as a sprained knee? Sprained knee is overstretching of the ligament, not a complete tear. While a pop followed by immediate and severe pain means the ligament has actually been torn completely. That has already been answered. Which ligament tear can cause louder pop sound? ACL tear causes louder pop sound because it has got thicker bundle fibers than the medial and lateral collateral ligament. Remember the difference in the swelling of ACL and meniscal tear injuries. Swelling in ACL injuries are quite quick to follow because ACL is a vascular structure and the swelling is due to the bleeding occurring there. In meniscal injuries, in contrast, meniscus being a non-vascular structure, there is no bleeding. Swelling occurs due to synovial reaction. Synovium is irritated and it takes longer time to secrete the synovial fluid. It may take a few days. Swelling of the knee in ACL injury is hemarthrosis, whereas in the meniscal injuries, it is effusion. On examination, inspection in acute cases, the swelling of the knee is often tense, knee remains flexed to accommodate this cross swelling. Active extension of the knee is painfully restricted. In cases of ACL tears, sag sign can be seen, and in cases of medial and lateral collateral ligament tears, bruising can be seen in the course of the ligament. In chronic cases, on inspection, always start with the knee flexed and look for the sag sign. If you find the sag sign, you have reached at your proper diagnosis. Look for the swelling which comes off and on, even if it is chronic cases, and there could be a quadriceps wasting as well. If surgery has been performed on the patient, you can see the scars of the previous surgery performed. Examination in acute cases or palpation, area is usually hot because there is blood inside. Patellar tap will be positive. Tenderness, try to elicit tenderness at the anterior tibial spine to look out for the avulsion tear of the ACL. Other bony tenderness are usually negative. Soft tissue tenderness is positive in the cases of MCL, LCL, or LCL tear in the course of their attachments. In the case of meniscal tears, joint and tenderness can be elicited. This is the avulsion tear. You can see PCL. This is ACL. Palpation in the chronic cases, temperature is usually normal. Tenderness hardly cannot be elicited. Swelling, if there is a swelling, sometimes it occurs, sometimes you may not get. Western the quadriceps will there, and movement of the knee will sometimes you can feel the crepitus in very late cases. Let us talk about the provocative tests, and there are certain tests that we are going to discuss and demonstrate. One is the anterior draw test. Instead of describing it in the bookish style, I will try to demonstrate it on the patient. Another is the Latchman test. Another one is the pivot shift test that I won't be demonstrating you. You go through it. And there is a lever test. So one by one we will be seeing. Put your hand under the upper calf, knees flexed, and put pressure over the lower quadriceps. If there is a tear of the ACL, the heel will not be elevated. In the normal, see the normal, it will be elevated quickly. This is the lever test. Now we will try to demonstrate all the tests that we have just enumerated together.
So first step is bending the knee 90 degree. Next step is I will stabilize it by sitting over the foot. The foot is stabilized. The third step is must ascertain the hamstring is relaxed. You know the hamstring is attached over the tibia, and if hamstring is tight, it won't allow tibia to come forward. And then catch hold of the upper part of the leg, both the thumb anteriorly closer to the joint line, and then you have to pull it. There are two methods of the pulling. You can pull it. It should be a constant forceful pull. Don't make a jerky movement. And the second one is straighten your elbow and then pull it. I will repeat here. I will push it. And I will push it here. This is posterior draw test. Pathological knee. Knee is flexed. Stabilize the foot by sitting over it. Identify the normal side, and this one is the abnormal side. So I am going to do the anterior draw test on the normal side, and I cannot draw it, it is negative. and then I will repeat it by pushing backward. Is the posterior draw test is negative. I will do anterior draw test on the pathological knee, and you can see it is coming up, but it is coming up from the sagged position, from the posterior position. There was a sag sign positive in it, and it is coming up to the neutral position. So this is the neutral position I have brought in, and then I am pulling, it is not coming up. But if I am pushing it back, doing the posterior draw test, it is going back. It means the posterior draw test is positive, not the anterior draw test. One is flex the knee 20 to 30 degree, stabilize the thigh with your another hand, and with my right hand I will be catching hold of the upper part of the leg. Again, I will try to put my finger closer to the joint, and then I will pull it. Should be pull, stabilizing this one and pull. I can do on both sides. This is one. But if patient is bulky, obese, you can put your own thigh behind the knee of the patient, and then you can repeat it. So it becomes easier for you to do it. Third method also. So we'll try the third method, which is very effective and less strenuous. Ask the patient to come on the edge of the table, knee on the edge of the table, where you can flex it, extend it, and then you apply on the lateral side. I am applying the knee extended and doing the valgus stress test. Same way I can do it the varus stress test. See it like this also. Varus stress test, valgus stress test. Flex it 20 degree, valgus stress test. Then varus stress test. Take out the patient's leg with the help of your arm and forearm. You can do the same. I am doing it. So this is the valgus stress test when the knee is extended, and this is varus stress test when the knee is extended. I can repeat when the knee is flexed, the same. It is easy now.
Grading is grade 1. Up to 2 or 3 millimeters, it is considered to be the normal laxity. So grade 1, 3 to 5 millimeter. Grade 2A. Remember, A is when you get a firm endpoint, and B is there is no endpoint. So grade 2, A, B both are there. Grade 2, 5 to 10 millimeter translation, and grade 3 is more than 10 millimeter translation. So how to know whether tear is complete or incomplete by doing the special tests? It is simple. Increased displacement of the tibia as compared to the uninvolved side is indicative of tear. Whether partial or complete, it has to be decided. But when during the Latchman anterior draw test, to get an endpoint with the laxity, it is suggestive of partial tear. Whereas laxity with no endpoint indicates a full thickness rupture of the ligament. There is a grading, IKDC, it is same almost. Normal 0 to 2, grade 1 to 5, grade 2, 5 to 10, and grade 3 more than 10. Imaging X-rays of normal, except in the cases where there is avulsion of the tibial spine. So it is an avulsion fracture that can be detected on X-ray. And the second way of seeing it is a segment fracture. Segment fracture is an avulsion or pull-up fracture of the lateral tibia by the lateral knee soft tissue structures. And this type of the fracture is considered to be synonymous with the ACL rupture. See this? This is the segment fracture. The lateral soft tissue structures have fractured the lateral side of the tibial condyle, and almost always there will be ACL tear along with it. So when the question is asked whether is it possible to diagnose ACL tear on X-rays in certain circumstances, is it yes? If there is an avulsion tear and if there is a segment fracture, otherwise MRI is the method of choice for the diagnosis. You can see the MRI is usually seeing almost vertical in normal anatomy. But when there is a tear, see this one has become horizontal. This is an acute complete tear, acute because there is hedginess and it is hypertense. See, it is normal one, it is almost vertical and ruptured, it has become hazy and horizontal. The treatment is, primary treatment is RICE therapy, physical therapy, and functional braces. Surgical treatment consists of ACL reconstruction mainly. Now question is whether single bundle reconstruction or double bundle. Most of the surgeons prefer single bundle reconstruction. Treatment of avulsion fracture that we have discussed, it is very simple. Reduce the fracture and put a screw there. Your ACL is repaired immediately. The treatment of the ACL rupture usually by autografts, and most of the time it is bone, patellar tendon bone autograft. So this is most common source of the graft. Part of the graft is taken for the patellar tendon, part from the patella itself, and then tibia, make a hole in the tibia, put the graft from here, the patellar tendon goes like an ACL, and here the patella itself is incorporated in the lateral part of the tibial condyle, and put your sutures here. So this is bone, patellar bone autograft. Complications, patella can be fractured because you are taking part of the patella. The re-rupture can occur with any of the graft. Sometimes semitendinosus graft is taken, and sometimes quadriceps tendon graft is taken. So these are the types of the autograft that you take. But many of the times you had to take allograft. Usually it is done in revisions because you have already tried, many surgeons have tried different types of the grafts, and there is no graft available for you. It is advantageous for the patient because there is no harvest site morbidity. It takes longer incorporation time, it is expensive, and there is a risk of transmitting the diseases, especially HIV and hepatitis. What happens to the new ACL? The tendon graft undergoes a process which is called ligamentization. The remodeling phase of the graft usually occurs between 6 to 24 months after the surgery, but sometimes may take longer. The new ACL most closely resembles the native ACL after 2 years of the reconstruction.